All right. Well, let's get started. Welcome, everyone, to AAST Virtual Grand Rounds. I'm Chris Michetti. I'm the chair of the Critical Care Committee for the AAST. And this month we have critical care experts on the hot seat. We're going to be going over some cases from our panelists. Before I allow the panelists to introduce themselves, I just have an announcement. As of 2021, AAST will no longer be offering CME for the live grand rounds. The CME will be available for the archive version of this grand rounds and those who watched this grand rounds. So we have some interesting cases today with our panelists. I'm going to ask them to introduce themselves one by one, starting with Dr. Carmichael.
Hey, everybody. My name is Sam Carmichael. I'm an assistant professor of surgery in the Division of Acute Care Surgery at Wake Forest University in Winston-Salem, North Carolina.
Thanks, Sam. Dr. Pathak.
Hi, I'm Abhijit Pathak. I'm at Temple in Philadelphia, where I'm the program director for the Surgical Critical Care Fellowship.
Thank you. And Dr. Seshadri.
Hi, I'm Anu Seshadri. I'm a second year trauma and acute care surgery fellow at the University of Pittsburgh.
Excellent. So we're going to get started with Dr. Carmichael's presentation first, and I'll be moderating and posing some questions within the presentation and some random questions to the panel as well if they come up.
Okay, let me go ahead and load my slides here, folks. How's that look, everybody? All right, fantastic. Let me just move this one pane over just a little bit so I can see everybody. Okay, perfect. Well, Dr. Michetti, thanks so much for having me and here to discuss an interesting case that we had here recently. So our case is a 38-year-old male with no prior past medical history. He was involved in an MVC. He was not restrained. He was ejected from the vehicle. He was a GCS of 3 on the scene and hypotensive en route. And on presentation to the trauma bay, the patient had improved his GCS to 13. He was on a non-rebreather. His systolics were 80 millimeters mercury and his heart rate was 130. He was moving all extremities. He was transfused 2 units of whole blood without improvement in his blood pressure. Transfusion continued with MTP. His FAST was positive and his chest x-ray and pelvic plain films were unremarkable. So at this point, what would you do? We've got a few different options here.
Okay, so Dr. Seshadri, this seems like our standard trauma resuscitation. What's your next move here in this patient?
So for me, we have a hypotensive patient who's not responding to transfusion, and we have a positive FAST. So that to me says that we have intra-abdominal hemorrhage. That's the source of our hypotension. And so I certainly wouldn't wait to insert an arterial line or proceed to CT scan. In my hands, it takes a little longer to get the Roboa catheter actually in the trauma bay and then into the patient than it does to get them to the operating room and potentially just get hemorrhage control automatically. And so I would just do D and proceed to the operating room for an exploratory laparotomy.
Dr. Pathak, you agree? You're going to stop by the scanner real quick just to make sure everything's okay and before you go to the OR, or what's your tactic?
Now, I with a positive FAST and a non-responder in the trauma bay, I would go directly to the OR.
All right, Sam, go ahead.
Yeah, I mean, we were compelled the same way, so we proceeded to the operating room. Just touching on a few references here. I wanted to start out with MTP. This is what I have in my mind when I think about MTP. That is the paper by Meyer and colleagues from 2017 in Houston. Every minute of delay in MTP activation is associated with 5% increased odds of mortality. You know, like the panel commented, we followed the ATLS principles of, is this person a responder or a non-responder? we really felt like this person was a non-responder or minimal responder, really at best. And so with a positive fast, that expedited our travel to the operating room with this final reference from Barbosa and colleagues saying the sooner you get to the operating room, the better for someone who's bleeding. Now, I wanted to share as well, got references in the form of a QR code here. If you wanted to pull out your camera, this will be kind of up there with each reference page, and it'll take you to my collection for this talk. Okay, so in the operating room, we found grade 5 liver laceration. Somewhat atypical because it spanned the left lobe and the right lobe, very, very central. So bleeding was initially controlled with Pax and Pringles somewhat, but he had some worsening stability requiring resuscitation. So at that time, we provided manual compression of his aorta with some improved physiology. Based on that, we made the decision to place a Reboa via left groin for intermittent occlusion, kind of to help with our resuscitation. So with that in place, I placed some topical chemostatics within the laceration and then applied external compression, that is Pax from without, to reestablish the anatomy. And with all that, he did okay. And so we were able to remove this Pringle, take down the balloon without any brisk bleeding. And then at this point, what would you guys do?
Dr. Pathak, you want to take the first crack at that? So we have proceeding to ICU to IR, or continue with your operation there.
Yeah, and in this case, I think the Reboa, you had the balloon was up, right, Sam?
We'd taken it down at the end of the case and didn't really have anything bleeding back up at us. So we had the Rommel down and we had the Reboa down.
Okay, and I guess the other is, what was the bleeding from the liver? Did it appear dark or did it appear bright red? I think that also factors into whether or not going to IR for angio may help. But what you're describing is a pretty devastating liver injury. I'd be concerned that there may be ongoing or development of ongoing arterial bleeding. So I probably would go to angio at this point.
I would agree with that. Do you disagree, Dr. Seshadri? Any special tricks?
No, I think I'd do the same, especially if you're having exsanguinating bleeding and you just got control removing the Pax. It doesn't seem the time you give. Going to IR also gives you some time to resuscitate while you're trying to improve your chances on the next operation.
Yeah, and this case makes me think, of the hybrid rooms that some centers have, that where you can just do this in the same, sitting in the same room. So what are you going to do, Sam? Yeah,
so our bias here was to go to the interventional radiology suite, which is just right across the hall from our ORs. And so kind of conversations we had in regard to management at the time kind of focused around a couple of different publications. So obviously surgical management, liver injury is super duper tough. We've talked about amongst our practice this paper recently, trying to consider at what point, if someone's eligible for a resection, should we do that? You have this reference from Pittsburgh, Dr. Seshadri's crew here that suggests, hey, think about a resection if you can. We didn't really feel like he had an opportunity for this, given that he had very central injury, so he didn't so much have a resectable option, although they demonstrated in 2008 9% mortality in their series of 56 patients. So then with kind of the benefit of Reboa, we thought, well, maybe there's some arterial hemorrhage in there, devastating injury, as you guys already pointed out. So there's certainly a possibility of maybe we're not seeing everything that is bleeding. I think our PACs did a good temporary job, but kind of further supported by this review done by the folks out at Harborview, Eileen Bulger and colleagues, that said, consider angioembolization after a trauma laparotomy. One of their references I thought was valuable by Schwab and colleagues in 2002 said, 62% of patients have bleeding on angio following perihepatic packing. However, there is some risk to this. You can get some hepatic necrosis in about 15%, so it's balanced there. My bias at this point in my career early on is that I'm probably going to favor going to IR for most of these folks with big bad liver injuries. Okay, so IR had active extract from the left and right hepatic arteries. GDA, splenic hilum, was seen on angio. GDA was coiled, then gel foam to the distal left and right hepatic arteries, and then distal and proximal splenic artery got gel foam and coiled also. So we went up to the TICU, not requiring vasopressors or further resuscitation. He was warm at that point, so we felt pretty good about that. Got completion CT scans. The only additional injuries showed there were rib fractures. And so, unfortunately, later on that day, this was overnight where we did his case. Later on that day, he became hemodynamically unstable in the early afternoon. Despite transfusion, got increased volume of sanguineous drainage from his temporary abdominal dressing. So partners made the decision to return to the operating room then. On removal of the VAC, they saw some small amount of bleeding from the abdominal wall, from the liver packing and splenic bed, and removal of the packs to evaluate for liver bleeding that had a central injury that resulted in significant bleeding from the mid portion. This was repacked, Ramel tourniquet was reapplied, and then the right colon and duodenum were mobilized in order to get inflow compression of the IVC. So this allowed them enough time to perform suture ligation of what they found to be a middle hepatic vein injury from the trauma and short hepatics on the IVC. So in this person's hospital course, they returned after 24 to 48 hours for removal of packing to the operating room, placement of drains for what looked like a bile leak given the ascites without a clear source, and partial abdominal closure. He had a rocky road after that point, had intermittent shock with end organ failure, hepatic renal, ARDS, considered ECMO for him. Worked him up with a CT scan that showed no PE and no clear suggestion of intra-abdominal abscess. So he underwent, for further evaluation, bedside re-exploration, and which was concerning for infected bilious ascites. Now what? Now what do we do?
So this is an open abdomen, Sam, or is this an open
He's
abdomen
open.
with bile leak?
Yep.
Dr. Seshadri, what are you going to do there in Pittsburgh?
Well, I think that you're not going to see it at the bedside. It's just going to be impossible. So I don't think I would do A. I think it would very much depend on what you're able to see and if you're able to really characterize that injury. It sounds like you had, a very large necrotic area of liver, and it was hard to see a discrete area causing bile leak, and which I think would make it difficult for you to actually repair it or place a T-tube if you don't know where the actual hole is. So it sounds like getting good source control by washing things out and leaving bigger drains and trying to temporize the patient's sepsis. But I would probably err to the side of ERCP, because those are probably at least a cleaner plane for them to try to get some decompression. And then you still have the option of trying to repair it later if that doesn't work.
Yeah, I mean, my bias is that ERCP this is a case where it has a benefit. I think it's really overused for bile leaks personally. People coming in with, 100 cc's a day out of a drain that get an ERCP, but this is certainly the opposite end of that spectrum. So I agree with that. Is that what you did, Sam?
Yeah, we sure did. We reached out to our GI colleagues for some endoscopic assistance there, which they were able to do for us. Let me move this down in case that's in the way. I wasn't sure whether our pains are in the way of the QR code, if anyone wanted those references. So in any case, we consulted gastroenterology for the indolent bile leak as bedside, as Anu mentioned, or OR exploration. 5 days into this patient's hospitalization would likely be unhelpful, non-therapeutic. So we got endoscopic biliary duct decompression. So I share this reference because this is described in the most recent guidelines for the World Society of Emergency Surgery. Okay, so the patient underwent ERCP with a 10 French stent placed in the right hepatic duct. A scheduled return to the operating room revealed some hepatic necrosis, which was debrided, and unfortunately discovery of some gastric perforations along the greater curvature, which were ischemic in nature. The greater curvature was resected with staplers, and some additional drains were placed. The subsequent return to the OR for washout and closure was performed without any additional pathology requiring intervention. In the ICU, during the workup of septic shock, we discovered an external iliac vein thrombus for which the patient was initiated on a heparin infusion. He also required CRRT for uremic renal failure and diuresis. And several days later, he had some bloody NG tube output and melena in the setting of physiologic decline. So an EGD was performed, and that revealed 2 sites of ulceration to the greater curve of the stomach. 1 required clips and epi injection. So last question here, what would you do for that DVT?
Dr. Pathak, what do you think?
Yeah, I mean, I think in this patient, you already have evidence that the patient had some bleeding. Not only that, you know, you're not sure if the patient's going to require further procedures requiring interruption of anticoagulation, and that's a pretty proximal clot. So I would err on putting a retrievable filter in this patient.
So just to keep us on time, Sam, why don't you keep going with your slides there?
Yeah, I think that was my last question. And so that is what we did. I wanted to share this reference here. That is the classic indication for IVC filter placement is kind of like we said, presence of DVT with absolute contraindication to anticoagulation. And then this from the chest journal that gives a contemporary conversation in regard to indications. So our practice is for placement of retrievable filters like Dr. Pathak said. And we did that for this patient. Okay, last piece here. So unfortunately, I had some concern for feculent drainage from the midline with abdominal wound dehiscence. He returned to the OR and then had liquefactive necrosis of his remaining liver without opportunity for resection here. He had a subsequent further clinical decline, presumed septic shock, suffered an arrest, and then passed away despite maximal efforts. So today, we kind of talked about the high-grade operative liver trauma that's super tough to manage, significant morbidity and mortality. We discussed operative management and the critical care challenges associated. So thank you very much.
All right, thank you, Sam. So we're going to just go right into Dr. Pathak's case. This is the critical care committee, but I hope you didn't think we were going to talk about hyperkalemia for an hour. These are, trauma critical care cases that are very interesting.
All right, let me unshare myself then. Let's see. Am I unshared already, Chris?
Yeah, we see Avi's slides.
Okay, I'm a little technologically challenged, so I'm not like Dr. Carmichael there. Unfortunately, I don't have any QR codes for you guys, but we're going to present. There's a 46-year-old male who came in with a gunshot wound ×2, one to the left cheek, one to the left anterior chest. He was agitated, not protecting his airway. We intubated him. He had decreased breath sounds on the left, and we needle decompressed, followed by a chest tube, which revealed a massive hemothorax. He was hypotensive with a systolic blood pressure of 76. We placed a left femoral vein cordis. We initiated our massive transfusion protocol, and prior to intubation, his GCS was 8, and he was localizing. In terms of his fast, we thought there was some pericardial fluid, and these are just his trauma bay x-rays. He had appeared to be a transcervical gunshot wound, and then a transthoracic with potential transmediastinal trajectory on the left. So we took him up to the OR, and as we got him on the OR table, unfortunately, he lost his pulses as anesthesia was getting ready to put A-lines and do their things. Started CPR and opened his left chest. We needle decompressed his right side just to take it out of the equation, and we didn't find any hemopericardium. He had some cardiac activity. He was in PEA, got pulses back, remained hypotensive. We cross-clamped him briefly and packed his chest to allow anesthesia to catch up. And we found the significant portion of bleeding was from the left upper lobe. Seemed like it was a proximal PA branch. Ultimately, we ended up wedge resecting portion of the left upper lobe, and then doing a smaller wedge resection to the left lower lobe. It exited the chest, the left lateral chest. There was no intercostal injury. Put the chest tubes in. We packed his mouth and nose. And in the OR, he got a close to a 1-to-1 resuscitation, as you see here, and TXA. Post-op, he was off pressors and was stable. And to better delineate the transcervical trajectory, we had gotten CT scans and ended up getting an angiogram, which was negative for a carotid injury. There was a concern of a staple line blush in the chest, and there was no active extract, but a cutoff right at the staple line. We just coiled it to take it out of the equation. That first night, he went up to our surgical ICU. He got a bronchoscopy because there was a concern that his ET tube had gotten dislodged during transport, and that just showed thin, frothy, bloody secretions. Tube was fine. And his initial ventilator settings, which you see here, he was on tidal volume of 450, 60% and 5 a PEEP, showed that his initial gas in terms of oxygenation, a little compromised, but nothing too bad. During the course of the night, he woke up and followed commands. However, also during the course of the night, he had developed progressive hypoxemia, requiring increased FiO2 and PEEP. And by the next morning, he's on 100%, 10 a PEEP. His plateau pressures are up and his PF ratio is 82. And his chest x-ray is shown right there. And we thought it was consistent with ARDS. Maybe, could it be from aspiration versus trolley? So what would we do now?
So you want vent management, vent settings, or
Yep. So what would you do now in terms of the management of severe ARDS?
Dr. Seshadri, what do you think?
Well, on the vent side, there are a couple of things that you can do. Your tidal volumes are on the higher end of the 4 to 6 mils per kg. And so you could decrease that somewhat, and then do a best PEEP trial. Try to identify how you can recruit that lung better to improve your oxygenation.
Dr. Carmichael, are you going to prone this patient right now?
I certainly think about all the adjuncts for someone in this type of position. Things that we consider are proning are steroids, are paralysis, and then I'm an early ECMO caller as well. I mean, if I think that someone's headed the wrong way with the potential to get worse, where we may require the assistance of lung bypass, then I'm a call early kind of guy myself. One other thing I would make mention that at least a consideration under these circumstances, there's a trauma. And so think about maybe a potential portion of those pressures is contributed to by some pleural process, but at the same time, I think you have an X-ray here where you can see lung recess on the other side, kind of clear evidence of the diaphragm. And so in that circumstance, yes, there may be some pleural hematoma or hemothorax contributing to the pressure, but you have chest tubes and you can see a diaphragm here, so less likely. So I think under these circumstances, maybe opening that thoracotomy would be potentially less helpful?
I'm gonna advocate based on evidence of improved mortality with proning and severe ARDS PF ratio less than 100. I think seriously about proning this guy, but Avi, tell us what you did.
Yeah, I mean, all those points are well taken, and we thought of, we need to reopen the chest. But again, you see the lung volumes are more than adequate, and we didn't have any retained hemothorax or anything that could explain the compromised ventilation. So what we did, we dropped the tidal volume down, increased his PEEP, sedated him more, neuromuscular blockade. We used pulmonary vasodilator. In our institution, we utilize inhaled prostaglandin, so we utilize that. And we thought about proning him. My concern was that he was a fresh anterolateral thoracotomy, and didn't want to flip him prone at the time. But what we did was we utilized rotational therapy on a Keen bed to try to maximize rotation for recruitment. And this progressively over the course of the day, it seemed like, on those settings, his plateau pressures continued to rise, and they were in the high 30s, and his PF ratio is 71 now. And now what do we do? We've decreased his tidal volume, we've increased his PEEP, we did some adjuncts. It's not getting better.
And is he having CO2 retention problems, or not so much at this point?
Very mild. His PCO2 we're in the 50s, low 50s.
Okay, Dr. Carmichael is a early ECMO caller, but are we at that point yet? Or Sam, are you gonna do something else to manage him? Unmute.
Yeah, I think I probably already called them. But that being said, I think that kind of based on Dr. Pathak's description, this more likely seems to be a parenchymal process, for which we only have kind of so much that we can mitigate with ventilator type management. Certainly has all the adjuncts. In real time, Avi talked about the proning surrogate, kind of the rotational manipulation that they have. I think we've kind of done all the stuff, due diligence there.
All right. Okay, keep going, Avi. Let's see what happened.
So what we tried next was we transitioned him to bi-level or APRV to see with an advanced mode of ventilation if we could improve his oxygenation. So you see the settings there. We put on a P high of 30, P low of 5, T low of 0.8, and 100%. With that, his mean airway pressures did increase and did end up requiring some vasopressor support after that. We had also gotten an echo while this was all going on, and that just showed that his LV was hyperdynamic. He didn't have any RV strain, and no regional wall motion abnormality, and no effusion. So he actually continued to worsen, and his PF ratio was now 57, and his pulse ox remained in the declined to the high 80s, low 90s, and eventually ended up, and we've sort of all been there, where you see that saturation sort of dip down, you bag them up, get them up above 90, put them back on the ventilator, and then you see the saturation slowly dip back down into the 70s. So we kept doing that, and then at this point, now what do we do?
So I see where this is headed, but Dr. Seshadri, tell me, is there anything outside of ECMO that you want to do with this patient now?
I think at this point, you've tried everything else. I think it was reasonable to do a trial of APRV or bilevel, try to maximize your ventilator settings as much as possible. But at this point, he's failing all the other adjuncts too, because you've already tried Velitri, you've already tried rotating him, you've already tried paralysis and increased sedation. So I think that at this point, it's time to pull the trigger on ECMO.
I had one question, Dr. Pathak. So kind of dividing this process into a few different categories, it doesn't sound like there's a pleural process. Sounds most likely a parenchymal process. What about tracheobronchial tree? I mean, did he have a whole lot of blood clots or secretions, or was there anything within his airway that you thought may be driving some of this potentially obstructive pathology?
No, I mean, like I said, initially he had been bronched and he had these thin, frothy, bloody secretions, which he continued to have. And he had multiple chest x-rays during the course of the day. So, you know, we would have expected that if he did have a significant clot or a mucus plug, that we would have probably seen some lobar collapse or whiteout or something like that. And we were, you know, a little less inclined to just bronch him if there wasn't an indication because of his hypoxia.
All right, let's keep moving. Go ahead.
So, you know, we're talking about ECMO, and many of you may be familiar. This was presented at the AAST. It was just a retrospective review of the ELSO registry and the use of ECMO in trauma patients. And really, you know, when there's no difference in mean survival between trauma and non-trauma. So we placed, you know, we had called our cardiac colleagues who placed our patients on ECMO at our institution. So we got placed on VV ECMO. They cannulated the right IJ and the right femoral vein. His initial ECMO settings, his flows were 4 to 5 sweep, 2.5 to 3. And his, you know, now what about, you know, now he's on VV ECMO. You know, would we do therapeutic anticoagulation, and what vent settings would we use?
So I'll jump in on that. I just, you know, I would be very hesitant to fully anticoagulate this patient, just for fear that you know, pulmonary contusion is just gonna blossom significantly, even though you embolize. So I think I would see if I could run the ECMO without that initially, and just try to keep him on vent settings to, you know, prevent further alveolar collapse. But you know, that's probably a big judgment call. What did you end up doing?
So, you know, there's some data out there, you know, obviously to support not doing therapeutic anticoagulation. And this is, most of them are single center studies. This is a single center study from Mississippi, and they found no difference in thrombotic complications between therapeutic anticoagulation and not. So no therapeutic anticoagulation for him at that time. And we placed him on low ventilator settings with a tidal volume of 250. His plateau pressures were in the mid-20s. And obviously with ECMO, there was an improvement in his oxygenation, and his pre and post gases are there with an appropriate step up, and his arterial PaO2 was 72. And then over the next few days, we got him off the paralytic, continued our rotational therapy. His pressures got weaned off. And then post-op day 3, we started on therapeutic anticoagulation. We thought it was at this point probably okay to do so. And then, you know, would anyone, you know, would they perform a tracheostomy on this patient? If so, when? Would they do open or percutaneous? And, you know, now he's a few days out, maybe felt a little more comfortable proning him. Would anyone prone him?
I do love the proning, but on ECMO, Dr. Seshadri, are you going to trach them now?
It seems like he's probably going to need a trach, but I would give him some time. I don't think that he necessarily needs that trach immediately. And part of that to me too will be to see where he goes, and he's on the therapeutic anticoagulation as well. And so once I did trach him, I'd probably do it open because of the therapeutic anticoagulation with everything going on. And also he had that transcervical gunshot wound as well. So it just seemed like it would be wiser to do that open, but I would probably wait at least a week, see how he did, and then go from there.
Yeah, I agree. I mean, I would advocate, you know, I want to see these patients on the downswing from their ECMO, not getting worse. But I think the trach benefits them. Most of our patients that have been on ECMO, you know, we've been pretty comfortable stopping the anticoagulation unless they had some dangerous thrombosis, stopping it for the procedure. So we would just perk trach them at the bedside. But I don't know that I've prone an ECMO patient yet, but Dr. Pathak, what'd you do?
So in terms of the tracheostomy, you know, at our institution, it's sort of on a case-by-case basis. So if you have patients who have underlying lung pathology, COPD, lung transplant, they're probably in it for the long haul. So our pulmonary guys will try to get them trach while on ECMO. And that'll help them sometimes get them off ECMO with their native lung. And you know, we in this case, this patient didn't have any underlying lung pathology, so we thought we would wait it out and see how he did. And again, same reasons for as Anu said, that we did an open, we would do an open tracheostomy in terms of therapeutic anticoagulation. Prone positioning, again, little controversial. You know, there's a risk for dislodgement of the cannula with proning. We have prone patients at our institution. When we do that, we utilize a specialty bed such as a rotoprone, where we're able to keep the lines and cannulas sort of neatly packed together, and we think it's safer. But again, you know, in this patient, we weren't early on, we weren't really trying to recruit anything. We just had his vent settings on a resting mode with tidal volumes at 250. So doing anything like that wouldn't have benefited him early on.
We have a question, but we're a little behind on time, so let's just move on if it's okay, Abhi.
Yeah, so, you know, he improved. We decannulated him on post-op day 9. Got a sense of what was going on with him in terms of vent. Looked like he was going to be in it for a little while, so we performed a tracheostomy. He also had a retained tooth at the base of the tongue, which ENT took out. We were able to fully liberate him from the ventilator on post-op day 17, and on post-op day 25, we were able to decannulate him and discharge him home. And this was his chest X-ray at his first post-op visit, which was about 2 weeks post discharge.
Excellent. That's a good outcome. All right, let's go into Dr. Seshadri's slides. Abhi, you didn't want to take that tooth out at the time of the thoracotomy? That was a rhetorical question.
So I'll be presenting on a different flavor of critical care. Instead of trauma, we'll be talking about it in an acute care surgery patient. I have no disclosures. So the patient is a 50-year-old gentleman who had no significant past medical or past surgical history. He just had recurrent pancreatitis secondary to alcohol abuse, but with no evidence of cirrhosis yet. And he was transferred from another hospital to our medical ICU with the diagnosis of acute necrotizing pancreatitis and in shock. So he had originally been admitted to this other hospital 2 days prior, stable, but with severe epigastric pain, and that was similar to his previous episodes of pancreatitis. And as mentioned, he was stable when they first met him, but by hospital day 2, he had developed tachycardia, hypotension, and had an escalating oxygen requirement, which elevated their concerns. And by hospital day 3, he was ill enough that he was requiring intubation and pressor support. And so at that time, they felt that their ICU capabilities were not high enough to manage this patient, and he was transferred to us. And so just for a little bit of laboratory data, on initial arrival, his white count was 10. He had a concerning lactate of 4.7, and his lipase was elevated to 1,000. But as you can see, he still had intact renal function. By hospital day 2, when he was starting to get sick, his creatinine had risen to 3.6, and he had a concordant rise in his potassium to 5.3. And it had gotten concerning enough on hospital day 3 with hyperkalemia to 6.9 and a creatinine of 6.3 that they initiated him on CRRT as well. So he was anuric and in renal failure on transfer. And so he was sent to our medical ICU for management of pancreatitis. And as mentioned, he was intubated and sedated on CRRT and anuric. But on arrival, the medical team had significant concerns because they found his abdomen to be tense and very distended, along with his other concerning findings, which included these vitals. He was afebrile, but he was tachycardic to the 1-teens. And he was certainly not hemodynamically stable because he was maxed out on pressors. So he was on norepi at 0.7, epi at 0.04, and vaso at 0.04. So he had extremely concerning hypotension. And he also had elevated peak airway pressures in the 40s and was requiring 100% FiO2 to maintain a SAT at 93. And at that time, his labs were notable for obviously the elevated creatinine. He was anuric and requiring CRRT. His white count had dropped to 1.5, demonstrating his concerning response. He had an element of shock liver. His AST was in the thousands, and his Billy was 2.1. He was acidotic with a pH of 7.14, and his lactate was 3.5. And so in the setting of his having a tense abdomen and him being hemodynamically unstable, general surgery was consulted to evaluate the patient. And just as a side note, he had imaging only from his hospitalization at the other hospital, which showed scattered areas of hypoattenuation within the pancreas that were concerning for necrotizing pancreatitis with surrounding inflammation and some free fluid, but there was no evidence of walled off necrosis or something discrete and drainable. So now that we have this patient in our medical ICU, I'll open up to the panel for what critical interventions are required for the management of this patient.
So Dr. Carmichael, I have a sense of what you might be doing. I want to know what you're going to do and if you're going to do it right there in that medical ICU room or what you have in mind.
Sure. I think the picture that Dr. Seshadri is painting is one of intra-abdominal hypertension. And so I think valuable steps there that they took. One thing that just I was kind of reminded of, you also, before you make an incision, which I think probably an incision would be the right thing for this person, given that they have multi-system organ failure, they have respiratory and metabolic acidosis, signs of potential malperfusion to the gut. The valuable thing I think that they also did was they had some imaging that suggested there's not an intra-abdominal process that could be drained as well, i.e. fluid or ascites or some pressurized volume that could be drained percutaneously. So the morbidity obviously associated with a big incision is greater than it is from a perc drain. Do a perc drain if you can do that. But I don't think this person really had that option. So I think they get a cut. Right there at the bedside? Or taking them to the OR? Yeah, honestly, I think that sooner is better. I think we run into logistics a lot of times. So if they had an OR ready for us to say, yep, let's go, come on down right now, then sure, we could do that. Or if they're in the ICU and it'd be easier to make an incision there in the ICU, I think that's fine too. Whichever's faster, I think. Yeah. Yeah, I know we try to make a decision as, are we getting into something more than we think, or is it really just release of pressure? In that case, we'll just bring the OR to us in the ICU. In the medical ICU, I don't know. I would love this patient in my own unit where we have the setup to do that pretty easily. But
What did you do, Anu?
That's a really good point, though, Dr. Michetti, because that CT scan was pre-operative, right, Anu?
It was from the other hospital. So it was on hospital day 1. We met him on his overall course, hospital day 3.
And so you didn't have any necessarily like concern for bleeding under those circumstances, because in that situation, then yes, operating room with adjunctive stuff, help, etc., transfusion capacity, anesthesia, that'd be ideal if you're worried about a bleeding problem, but a decompressive problem, sure.
I think, sorry, the other thing I would just add is whether we thought the patient would be safe for transporting to the OR. So these are all local, institutional factors. In our institution, our ICU is on the 9th floor and our ORs are on the 2nd floor. So if we feel that there may be an unsafe transport, then, we make the decision to open bedside.
I think either would have been reasonable. And then the other question about the fluid in the abdomen. So they checked a bladder pressure, which was elevated, and they did an ultrasound of the abdomen, which didn't show a ton of ascites. So to your point, temporizing with a drain wouldn't really have worked. And so he did have abdominal compartment syndrome, which, as we know, occurs in a combination of fluid resuscitation, ascites if they have it, fluid collections if they have it, and then bowel dilation. He had these signs and symptoms, which were a tense abdomen, oliguria, increased peak airway pressures, and you can measure bladder pressure, as we talked about, for that quantitative diagnosis. And so I looked at a systematic review of 7 studies that looked at patients with acute pancreatitis and abdominal compartment syndrome. And I thought it was pretty notable that the prevalence of intra-abdominal hypertension in these patients is actually quite high. It's documented at 54%, and abdominal compartment itself is at 22%. So that's a significant number of our patients that have acute pancreatitis. And then the patients that have abdominal compartment syndrome related to their pancreatitis have a very high mortality. So it ranges, it's a wide range, but it's 25 to 83%. And then, as discussed, you can consider temporizing with a percutaneous drain if it's the ascites more than anything, but typically we manage this with an incision. And that's what this patient got. So he was able to actually be brought to the operating room. I think the medical ICU, we have a very seamless way to do bedside XLAPs in surgical ICU. I think it's a little harder in the medical ICU for them to manage the room with that, and anesthesia felt comfortable bringing him down. And so he was brought to the operating room for an exploratory laparotomy. And he was found to have intra-abdominal hypertension, but he had sequela of it as well. So he had 140 centimeters of small bowel in the right colon that were necrotic. And so they were resected and he was left in discontinuity. He also had evidence of necrotizing pancreatitis that was visualized, but it was not explored, it was not debrided. The retroperitoneum was left in place. And then a temporary abdominal closure was placed with a plan for an operative second look. And this was the pathology from his original operation.
Anu, is this patient chemically paralyzed prior to that decision, or were the signs just overwhelming that he had ACS?
The signs were just overwhelming. They didn't paralyze him for that. And then his post-operative course was notable for multiple washouts, but by hospital day 8, he was able to be closed with peripancreatic drains that were left, an end ileostomy, so he was not put back together, and then he had a skin-only closure because he was still so dilated. And he sort of poked along. He continued on his CRRT. He had a very slow vent wean. He had a slow return of bowel function, so he was started on TPN. But that slow return of bowel function was concerning, as well as fever to 38.4. And so on hospital day 12, a CT scan of the abdomen and pelvis was obtained to see if he had intra-abdominal sepsis that was contributing to his overall picture. And so here are a couple of cuts from his CAT scan, where you can see that things have significantly evolved since his original CT scan. And the read noted severe, near complete necrosis of the pancreatic neck and body with small amount of residual pancreatic parenchyma involving the head and tail. There were now clear, discrete peripancreatic fluid collections. And then they also noted, incidentally, that the splenic vein was occluded, but the SMV and portal vein were patent. So based on this information, the patient's clinical decline and new CT scan findings, what would you do?
Do any of our panelists have a nice succinct answer to that?
Go ahead, Avi.
Yeah, I mean, I think it looks like there's a peripancreatic collection at the tail there, right? From what I saw. So I would do percutaneous drainage of that. And in terms of the SMV thrombosis, you know, it occurs, as you know, very frequently, probably with very severe pancreatitis, acute necrotizing pancreatitis. So, you know, I guess, you know, you could make an argument to anticoagulate, but I don't, you know, unless it is more proximal or is progressing more proximal, you could leave it alone.
Yeah, I'm kind of a similar opinion there too. And one thing that Anu mentioned that I think is critical here is that the retroperitoneum remain intact on their initial operation as well. So in my mind, that means opportunity for a minimally invasive approach to the retroperitoneum also, because you have a contained space there. So VARD, or rather a perc drain to VARD, or VARD straight away, depending on your practice or opportunity there. So, and then as far as the thrombus goes, yeah, I guess I think about a more central thrombus in the form of portal vein, where in my mind does enter non-occlusive mesenteric ischemia. So I may be more tempted to attack that with anticoagulation in an otherwise high risk person versus other locations, which may just be associative with their inflammation.
All right, let's keep going.
So for the pancreatitis and necrotizing pancreatitis itself, we agreed with you guys. We did a step-up approach, which that's the minimally invasive method to debride the necrotic pancreas. As you guys described, you start with percutaneously placed retroperitoneal drains, and then sometimes that just does the trick and it gives you the control that you need. But if needed, then you can use those drains as a guide for debridement operatively. And so if they do well with just the drainage, then great. But if not, they can still do well. And so the data shows that patients that have step up have less new onset multiple organ failure than the patients that go straight to open necrosectomy. And there's no worsening mortality in the step up approach. So it has benefits without increase in mortality. And so I've seen it done multiple ways. So once you have the drain in place, you can cut down on the drain itself and then cut down into the retroperitoneum. Or you can trade the drain out for a port to be able to achieve entrance into the retroperitoneum using a Seldinger technique. And then I've also seen multiple ways of doing it with the type of scope that you use. So you can use a cystoscope or a laparoscope, just something that gives you visualization into the retroperitoneum. And I found some interesting literature that's a little bit more recent that you can also do a step-up approach using endoscopic transluminal drainage with endoscopic necrosectomy as well. There was an RCT in the Netherlands of infected necrotizing pancreatitis patients in 2018, which was a multi-center RCT with 19 hospitals in the Netherlands, almost 100 patients, where the patients were randomized either to an endoscopic or a surgical step-up approach. And they found that there was no difference in mortality or new onset organ failure, bleeding requiring intervention, visceral perforation requiring intervention, ECF, or incisional hernia. And they found that there was a lower incidence of pancreatic fistula in the endoscopic group, which makes sense because your drains are creating a pancreatic fistula. And so doing it endoscopically is also an option. And so what we did for this patient was we started a heparin drip for the splenic vein thrombosis, and we started our step-up approach. So he had a 12 French drain that was placed in the peripancreatic collection by IR. And then on hospital day 27, a VARD was performed using a cut-down technique. However, by hospital day 32, he suddenly had increasing pressor requirements and then bloody output from his drains and his midline incision, and his hemoglobin had dropped to 7. So now new concern for bleeding. So what are the possibilities and what would you guys do?
Why don't you, if it's okay, just move us along and ruin the surprise for us so we can make sure we have time for all the cases.
Well, I think that Dr. Pathak had mentioned it earlier, which is that these patients have a really high risk of bleeding. And we had heparinized the patient. And so the patient was taken to IR to take a look, and they found some active contrast extra from a distal IMA branch. So they embolized it. And then we turned off the heparin, and we just kept it off and kept the patient on DVT prophylaxis. And so the thing that I found in the literature is that, as we know, splenic vein thrombosis is common in pancreatitis, and it's most common in the splenic vein, although the portal vein and the SMV can be involved as well. And there's no clear consensus on what to do about these splenic vein thromboses. And so there's a very wide range in the literature, with some people saying don't ever anticoagulate for them and just wait for bowel ischemia to happen. And then there's some people on the complete other end that say you should give prophylactic systemic anticoagulation for all pancreatitis patients. So the pendulum swings widely across the literature. And this is demonstrated in one review of 16 studies where about 50% of the patients received anticoagulation. So it's a coin toss across the country whether people are anticoagulating or not. But notably, the patients that were treated had a 14% recanalization rate, while non-treated patients had a not much lower recanalization rate of 11%. However, the treated patients had significantly higher bleeding complications at 16% compared to 5%. And so while the literature varies widely, a lot of authors suggest that if it's just the splenic vein, the risk-benefit ratio is on the side of not anticoagulating. But if the mesenteric veins are involved, then it's dealer's choice and your specific concern for your patient. You can either wait for evidence of ischemia and then anticoagulate then, or start anticoagulation knowing that this is the mesenteric veins that are being involved. And so just to close this case, we saw that abdominal compartment syndrome is really common in acute pancreatitis. It incurs a high mortality for those patients, and so patients should be monitored closely for it. The step-up approach significantly improves patient outcomes, and you can do it endoscopically if your hospital has the capabilities to do that. And then anticoagulation for splenic vein thrombosis in pancreatitis patients is quite controversial, but it seems like the predominance of the literature is to say if it's only splenic vein thrombosis, then consider watchful waiting because there's a high bleeding complication risk.
All right, excellent. We do have a fourth case. If you all are able to hang out for a few more minutes, and
it's worth it. Hang in there.
I'll share my screen there. All right, so let's go here. All right, so this is a 23-year-old brought to the trauma bay after an isolated self-inflicted gunshot wound to the head, who's hypotensive in the pre-hospital setting, gets TXA and a unit of red cells by EMS and is intubated by them, and comes in the trauma bay with active bleeding from a large wound on the left side of his head and visible brain matter. So this wound is covered and wrapped, and in the trauma bay, he's hypotensive to 62, and you're doing your primary survey and he arrests. So what are you going to do about that, Dr. Seshadri? And I guess, just to be blunt about the question, are you going to resuscitate this patient or are you going to pronounce them?
I would resuscitate this patient. If it's an isolated gunshot wound to the head, I would perform a CLS. I wouldn't open the chest or anything like that, but I would resuscitate the patient partially for the family to be able to say that we've done everything and potentially give them an opportunity to come in and say goodbye. And then partially for the benefit of potential organ donation.
Yeah, well, I'm glad you mentioned that because this is a great paper that came out last year in the Open Journal by Rob Winfield and lead author Leanna Robinson of 825 patients with gunshot wounds to the head and CPR. So these are all CPR patients, most of them pre-hospital CPR. 2.1% survived to discharge, 17.5% were eligible donors, and about 10%, 1 out of 10 overall, became donors. And so when I think of this kind of patient, I think of patient-centered care. Yes, this patient has a high chance of dying, but what are their wishes for their medical care? If organ donation is one of their wishes, I want to make that happen for them. The things in this study that came out to correlate with successful organ donation were the volume of crystalloid that they received and replacement of at least one hormone, thyroid hormone, steroids, vasopressin, etc. So we resuscitated, got return to circulation, MTP was initiated, and the TXA drip was followed up. He was still hypotensive, so we started a vasopressin drip there in the trauma bay. He stabilized enough for us to get him to CT and then to the ICU, but the CT really showed a devastating injury. This isn't the exact CT from that patient, but this is a transtentorial, devastating, essentially non-survivable injury. The literature has several good articles, from the one from Denver at the top and Tucson at the bottom, showing aggressive management of these kinds of patients occasionally will result in survivors, but also results in successful organ donors. Sorry, no QR codes for you. In the trauma ICU, the hemorrhage stopped, hemodynamics normalized, the left pupil was fixed and dilated, the patient was not breathing above the vent, had no cough or gag reflex, and the ICU team essentially thought he herniated and was brain dead. The OPO had already been called early about this patient, and the family is very accepting of that, and they ask right now if you can extubate the patient for comfort care. So Dr. Pathak, what are you going to do? Are you going to extubate this patient that you think might be brain dead?
Yeah, I guess, it would depend on the discussions with the family, number one. And number two is if the OPO was already involved, it might be a chance for them to have a discussion about donation after cardiac death, since we haven't pronounced him brain dead yet.
Yeah, this is one of those, tricky situations. And I find in my experience, I've had in early career, a lot of conflict about this and wondering how to approach this situation. This paper that came out last year in JAMA, August 2020, the World Brain Death Project, a really excellent resource. I highly recommend it. And they also recommend the point that, you don't need to ask for consent to do a brain death examination. And I think from just a general medical care standpoint, if you think a patient has died, I think I would advocate that we have an obligation to pronounce that patient dead. And it doesn't matter if they died by brain criteria or cardiac criteria. So we would try to go ahead and explain to the family that we needed to, perform an examination to see if this patient had already died. So
Chris,
we did.
Chris, just to echo, when I mean talk to the family, to get a sense of, many times the family has sort of made up their minds that they want the tube out. You know what I mean? They want to go directly to comfort care. And then if you do your brain death exam during that time and declare him brain dead, then there's some time period that may take for organ procurement to occur. You know what I mean? So if families are willing to wait for that process, then I think you go ahead. But if they want to have things resolved and go directly to comfort care, a lot of times our OPOs will do a rapid recovery with DCD.
Yeah, and that's why it's essential to get the OPO involved early. And what I've said when this has happened, in my experience, I just tell people I don't think it's fair to pretend that a patient is not dead and extubate them for comfort care with the intention of them dying from a cardiac standpoint outside of DCD when they really already died, right? That's not, that doesn't seem appropriate, but
Agreed.
DCD should be on the table.
Mm-hmm.
So one other piece, I was going to ask one other piece. This is a logistics question: is when in the setting of let's just say severe trauma, do you contact the organ procurement organization, like from the ED once they get to the ICU, or sort of where logistically is that phone call made? I mean,
that's a critical point, Sam. I think in the donation world, we advocate if they meet clinical triggers there's pretty much nationally accepted triggers. They're not the same everywhere, but a patient who you think has a high likelihood of arresting or proceeding to brain death, or has a low GCS without sedation, definitely if the family brings up the idea of donation, the earlier the better. It just smooths the process. In this patient, we brought the family in the room because there is evidence that having the family there while you do the brain death exam really allows them to understand what brain death means, and also results in them accepting organ donation at a higher rate. But this patient had no pupil exam on the right because of the gunshot wound, and no vestibular coccular reflex on the left because of damage from the gunshot wound, so no cold calorics, but otherwise had no reflexes in the brainstem and failed an apnea test, so was apneic. Are you going to declare this patient now, Sam, or no, based on that exam?
Yeah, this is a tough one. I think under the strictest circumstances where you cannot complete a brain death exam, a clinical brain death exam, that me personally, I think I would probably proceed to some kind of imaging study for reassurance and definition.
Yeah, I just, for the sake of time, I'll go on a little bit here. So that the World Brain Death Project, and a lot of people are familiar with the AAN guidelines, which essentially set the standard in this country for the brain death. Ancillary tests are recommended if you cannot complete any component of the exam, with the exception of the doll's eyes test in a patient who might have a spinal injury. So in our trauma patients, we obviously wouldn't move their head sharply side to side if we suspect a cervical spine injury. But if you can't do a pupil exam, if you can't do a cold caloric, ancillary tests are recommended. And cerebral angiography being really the gold standard, but nuclear brain flow also acceptable. The AAN guidelines, last updated in 2010, advocated that EEG might be acceptable. That has to be a specific kind of EEG, not just your I'm looking for seizures EEG. But the World Brain Death Project said not for routine use. So this patient got a nuclear brain flow study and showed the hollow skull phenomenon, no flow. So that allowed us to pronounce him dead. What is the time of death when that happens? Well, if you're not doing ancillary testing, if you just do your exam and apnea test, usually you do the apnea test last, and then it would be when the PCO2 reaches the target. If you happen to do an exam last, it's the time of the completion of the second exam. And if you do an ancillary test, then it's the time that the ancillary test is officially interpreted by the radiologist. So we went ahead and did that, and we declared this patient dead by neurologic criteria with that ancillary testing, met with the family, with the team. The family accepted the death, and the OPO then explained to the family that this patient had first person authorization, meaning they had on their driver's license that they wanted to be a donor, and that we were going to plan to proceed to donation next morning. The family did not like that idea and wanted to refuse and not allow that to go forward. So, Dr. Seshadri, what are you going to do in that tricky situation?
I think you're lucky because you have the patient's known preferences, his known wishes. And so I would go by the patient's preferences, just like any other written advance directive.
Dr. Pathak, any difference of opinion there? Or?
Yeah, it's a little tricky, and we've run into this at our institution, but we've never really forced the issue, with the family in this instance. So even though the patient's driver's license may have said that, even though we can go ahead, we've sort of gone by the family's wishes, and that's also in conjunction with our OPO as well.
Good. I'm glad we have a little controversy here. So, so when a patient makes a designation like that, it's a legally binding document, and unless there is strong evidence to the contrary, and some would argue even if there is evidence to the contrary, by law, the Uniform Law Commission, the Uniform Anatomical Gift Act, which was back from the 80s but revised less than 2006, basically states that in the absence of an express contrary indication by the donor, a person other than the donor is barred from making, amending, or revoking an anatomical gift. In other words, this is legally binding. and must be followed through just like any other medical wish, just like, I have appendicitis, I would like my appendix taken out. You have to have a unusually strong reason to say no if that was medically indicated. So the law states this person must proceed to organ donation. There are cases where the OPO, the family get together, there must be strong circumstances to not go with that. So to conclude this case, which is our final case, surgical critical care team, the OPO did meet with the family and explain that the patient went to organ recovery, against their wishes, but with the patient's wishes. 7 organs were recovered for transplantation from this brain dead donor. The OPO always follows up over time with these patients, and 3 months later, they were, in a different state, more accepting, and were actually kind of grateful the fact that their loved one saved so many lives. All right, so
just as a comment, our OPO is very aggressive with trying to get as many procurements as possible, but they spend a lot of time with the families from like the instant, and that to your point, having them involved incredibly early lets them spend a ton of time with the family, so that way they can build a rapport and then have those difficult conversations that Dr. Pathak was talking about when they're around the time of maybe having a conflict with the patient's expressed wishes. So they actually have a really good recovery rate.
Chris, there's a couple comments or questions in.
There's several comments or questions. I like that. I just want to say that, we approach organ donation from the patient-centered standpoint. This is not about what the family wants. We know that it's legally the patient's autonomous wish that counts. And if the patient dies with a donor designation, the patient's wishes must be legally and medically carried out. And you can't wait till the last minute to think of that stuff. You need to be resuscitating the patient so they're able to be an organ donor, because hey, if I come in your trauma bay, I want to be an organ donor, please resuscitate me so that can happen, even if you can't save my life. But since it's late, I'm not going to be able to get to all these good questions. But I really want to thank all of our expert panelists here for participating today in the really interesting cases. We kind of really blurred the lines between trauma, critical care, acute care surgery. Had some great discussion. So thank you to the audience for attending today's grand rounds. I'd like to remind you, please turn in your sign-in sheets by Friday, June 18th for this to the AAST office. And hope you join us for the next grand rounds on July 14th, which is going to be Experts on the Hot Seat International Edition. Thank you, everyone, and have a great night.
Thank you so much.
Thanks, guys.
Thank you.